Good afternoon. I'm Cindy Hall, president of the Women's Congressional Policy Institute, or WCPI, and welcome to our Capitol Hill lunch briefing, Menopause and Midlife Women's Health. Thank you to those of you attending in person and to those of you joining us by live stream. As most of you know, WCPI is a nonpartisan, nonprofit public policy organization whose mission is to bring together a community of bipartisan women policymakers and trusted partners to advance issues of importance to women, develop the next generation of women leaders, and foster a more effective and representative democracy. We work closely with the members and staff of the Bipartisan Women's Caucus. Women's health has been a priority issue for the caucus and our organization for several decades. Today, we will be hearing from a very distinguished panel, including Dr. Genevieve Neal Perry, Karen Giblin, Dr. Janine Austin Clayton, and our moderator, Christy Bloomquist. Each of them will bring a different perspective to this important discussion, and we thank them for participating. Our special thanks to Astellas for their support for this briefing. We appreciate their commitment to women's health, including a focus on menopause and midlife women's health. I would like to thank our congressional briefing co-sponsors, the leadership of the Bipartisan Women's Caucus, Congresswomen Kat Kamak and Susie Lee, co-chairs, and Congresswomen Monica De La Cruz and Amelia Strong-Sykes, vice chairs. I would like to acknowledge a VIP in the audience in WCPI's view, Dr. Nancy Lee, who is the former Deputy Assistant Secretary of Women's Health and Director of the Office on Women's Health at the Department of Health and Human Services for a long time. She was our longtime partner, and we held several events on midlife women's health and menopause over the tenure for Nancy. So we are thrilled you're here to join us. We will be posting live on social media during the briefing, and we encourage you and others to please join us using the hashtag WCPI Health. I'm now very pleased to introduce Christy Bloomquist, Vice President of Government Affairs and Policy at Astellas, who will be our moderator. Christy leads the Government Affairs and Policy team and is responsible for developing, communicating, and implementing Astellas's federal and state government strategies, engagement activities, and policy development across all functional areas. She has more than 20 years of experience working to ensure access to medicines for patients across the U.S. through robust government partnerships. Christy?
Great. Well, thank you so much for the introduction, and it's great to see all of you in person as well as on the live stream. I thought what I'd do is offer a few remarks of my own, and then we'll introduce each of the panelists, and they'll share some perspective, and then we'll open it up to Q&A from the audience. And so really look forward to hearing your questions as we talk about this important topic. So this is a really exciting time to be talking about women's health at midlife, and internally we talk about it as WHAM, because sometimes women's health at midlife and all that comes with it can feel a little bit like a big wham. You're like, what happened to me? Especially when you experience your first hot flash and all that might entail. But we think that, this is a great time to talk about this important issue, and Astellas is certainly thrilled to be part of this forum. So a huge thank you to WCPI for their efforts to bring this program to life. From an Astellas perspective, we use data, educational resources, and innovation to help women at midlife. And we want to make sure that they feel heard and validated about their unique healthcare needs. I don't need to tell all of you that women's health at midlife has long been ignored. It's an area where there's tremendous stigma, lack of understanding, and there's limited guidance, support, and sometimes solutions being offered, including in the policy space. And despite being a natural part of midlife, menopausal symptoms such as hot flashes can have a really negative impact on the quality of a woman's life, her interpersonal relationships, workplace contributions, and ultimately economic outcomes. All women who reach midlife will experience menopause. It's one of those universally experienced parts of life. And about 80% of women in menopause will experience a hot flash. And some will suffer from menopause for a decade or longer, especially Black and Hispanic women who often have symptoms that start earlier and are more severe and can be longer lasting. In fact, the Mayo Clinic found in looking at the cost of lost workdays and productivity caused by menopause as a general impact, it can cost up to 1.8 billion in lost total workdays per year. And despite these challenges, we find that physicians are not always trained to have educated conversations with women about menopause and to prepare women for these changes. Nor do employers necessarily have the tools that they need to help women through these transitions through menopause-friendly workplace policies. But change is becoming because women are engaging and they're raising voices, and men as well. We're so appreciative for everyone who is part of the conversation. Over the past year, we've seen an increasing number of policy solutions being offered, and that helps to elevate the conversation, and it also sets the stage for larger changes to happen. And these changes can include establishing regional centers of excellence to improve professional training resources for healthcare providers, creating public education programs tailored to groups to help communicate and talk about the impacts of menopause, expanding occupational health research to better understand workplace stressors related to menopausal symptoms, and investing in future research. Such bipartisan policy concepts, coupled with efforts to educate and engage employers on best-in-class policies, will help us really tackle some of the issues that can go with menopause and lead to some of the stigma and lack of discussion around this important topic. Efforts aren't just limited to policy solutions being offered on Capitol Hill. The White House initiative on women's health research included mention of menopause, as did a subsequent executive order issued by President Biden. So we're thrilled to talk about these developments. We're thrilled to have more of a conversation on menopause today. And again, really thank all of you for being here to take part in the conversation. So with that, I am excited to introduce our first panelist, who is Dr. Genevieve Neal Perry. Dr. Genevieve Neal Perry, Robert A. Ross, Distinguished Professor and Chair of Obstetrics and Gynecology at the University of North Carolina School of Medicine. In this role, she oversees more than 90 faculty members and 40 residents and fellows, and more than $20 million research program. Dr. Neal Perry is a national leader in women's health research and reproductive endocrinology. Her research program is focused on environmental and nutritional modifiers of fertility and the menopausal experience. Prior to her current position, Dr. Neal Perry directed the Division of Reproductive Endocrinology and Infertility at the University of Washington and opened the Cancer and Reproduction Unit at the Seattle Cancer Care Alliance, where she helped ensure people diagnosed with cancer have faculty fertility and menopausal care. So, Dr. Neal Perry, it's wonderful to welcome you. And I will say, in a true show of how important this issue, her flight out of North Carolina was canceled last night, and she drove up here so she would be here for this important conversation. So thank you for being here. We really appreciate it. Over to you.
Sometimes when I hear people talk about me, I'm like, who is that? So before I start, what I'd like to do is just, if you know someone who is menopausal, perimenopausal, raise your hand. Okay, that is nearly everyone in this room. And that speaks to just how many people are affected as well as family members. So it's not just about the individual who's affected, but it's about the impact of those that they care about and those that they work with. So menopause, what it reflects is the loss of ovarian function and a loss of hormones. And with that, there is an explosion of a variety of things that include hot flashes, that include mental fog, and we'll talk a little bit about that. Okay, so before the menopause, there's a perimenopause, and that's the time leading into what we know as the menopause. The menopause, again, is characterized by the loss of estrogen, the loss of progesterone, and those trigger changes in the brain that then have this impact on hot flashes. Next slide. When we talk about menopause, generally the average age of menopause is about 51. The average age of the perimenopause is somewhere between 40 and 50, but menopause can happen at different times. If it happens before the age of 40, that's considered premature menopause. If it happens between 40 to 45, that's considered early. And there are reasons why this is important because there's also increased risk for those people who are impacted. So how do we diagnose menopause? There is no lab, no test that you can do to actually diagnose menopause. It is what we call a retrospective diagnosis, meaning you did not have a period for a year. That is the only way that it's diagnosed. And I say this because if you go online, there's 1 million tests that women order that actually is just a waste of money. So there's predatory activity because people recognize this is such a vulnerable time for women. So when we talk about the symptoms of menopause, the most common symptom is the loss of menses and irregular periods. The second most common symptom are hot flashes. And you'll see that there are other things that are listed here. Weight gain, mental cognitive changes, mood changes, and all of these things impact those that are affected. And really important with this is that it's often misdiagnosed because there's so many things going on that when an individual presents to their doctor, to their healthcare provider, it's often confusing and dismissed. And I see a lot of people who have been searching for answers just for this very reason. Next slide. So what is a hot flash? It is an intense onset feeling of hot. It is just primarily above the chest. So it's not like you're exercising where your whole body is hot. It's really above the chest. It can be associated with palpitations and anxiety. Could you imagine just having this happen? I can tell you this is me. Okay, this was me in 2015. This is me today. So I'm a Black woman, and I am one of those numbers of people who actually have experienced it for more than 9 years and probably be 10. So with that, there are some ethnic and racial differences in hot flashes as well as in menopause. Hispanic women and African American women will have the onset of menopause at least a year earlier than their Caucasian counterparts. And this is important because, again, it's often missed because it's happening earlier than what we anticipate, and the symptoms seem so vague. So when we talk about hot flashes, which is one of the main sources of discomfort and dysfunction, you can see that the duration varies by race and ethnicity. Asian women tend to have a shorter period. And I say that with a little hesitation because part of it may be that we just don't understand the cultural description of menopause. So how we define it here in the States, that experience may not be the same for other cultures. So at least by our standards, Japanese and Chinese women have a shorter duration of hot flashes. When you look at African American women and Hispanic women, you see that it can be anywhere as much as 10 years. And that's a long time to have your life disrupted, which then has potential impacts on your work life. So I say all this, but I also want to say, the menopausal experience is not just hot. There are a lot of other things that happen. Next slide. And what you see here are just a list of things that people complain about. They complain about brain fog. They complain about sleep loss, difficulties with memory, difficulties with focusing, multitasking. The good news is that this is short-lived. It's not forever. So there's just a period of time when women may need a little bit more support in order to get over this hump. Now, with that being said, there are treatments for hot flashes that are FDA approved, but you will see here on this list that they're not nearly enough. They're just a handful. So this tells me we need more research. We need to understand more how we can help women who are affected. Next slide. And despite the fact that there's treatments available, a recent study found that 73% of women actually do not have treatment, although they have what we call bothersome and disruptive hot flashes. So why would we even care about this? Next slide. Well, if you want to get down, if you're someone who likes numbers, 6,000 women daily enter menopause. 2 million women annually enter menopause in the United States. And if you consider that the average woman lives into her 80s, that means that she will spend about a third of her life in menopause. It is one of the most common reasons that women seek healthcare advice, as well as one of the most common reasons money is spent for healthcare. We know that it's associated with the reduced loss of quality of life for those that are affected and their family. And if we think about it globally, it's more than 40 million women. That's a lot of people. Hot flashes, when they're severe, they're more likely to be associated with heart disease, depression, cognitive dysfunction, Alzheimer's, sleep disruption, fatigue-related accidents, things that, again, we don't talk about, as well as hip fractures. Next slide, please. So what are some of the barriers to menopausal care? Next slide. Cultural. In the United States, it's taboo to talk about menopause. I can tell you myself, I never had that conversation with my mother. What was your menopausal experience like? Because it wasn't something you talked about, that was private. Very much like fertility. You don't talk about your fertility in the United States. There's shame because you're no longer fertile. In the United States, what do we value? We value young, we value fertility. And so if you're entering into that phase of your life, you often feel like I can't talk about it because then I'll be revealed. So when we think about it from a perspective of research, the most common delays in care and diagnosis is that women are marginalized when they have these experiences, the cultural value of youth, lack of an active vocabulary. So how I describe menopause may not be the same way you describe it. My experience may not be the same as your experience because it's not a monolithic experience. And so it makes it very confusing. There are social factors, there are economic factors, there are a whole host of factors that will impact how we manage or don't manage menopause. Next slide. So bridging the gap. So why do hot flashes actually happen? If I told you that we did not know until about 10 years ago, would you believe me? This is something that affects more than half of our population, yet we had no idea why. Next slide. Well, it is all in your brain, right? When women were having hot flashes, all in your brain, shut up, just suck it up. Next slide. Well, it is all in your brain. It's about candy. Next slide. It's about candy neurons. And there are these little neurons located in the brain that are responsive to estrogen. And when estrogen is no longer available, they misbehave. They trigger hot flashes. So not a sweet event. Next slide, please. So, it's really important that we understand how hot flashes happen and some of the symptoms that are associated with those hot flashes in menopause. And we need to really invest in studies that are going to help us understand and actually manage those people that are affected. And because of this, we now have new therapies. Next slide. And the one drug that I want to call out to you is fezolinetant. It's a new drug that was FDA approved, but what's unique about it is it actually specifically affects those neurons that trigger hot flashes. The first time that we actually have a drug that is specifically targeted to the cause of hot flashes. Next slide. So I'm going to end with this comment here, and that is that the data presented reflects clinical data from people who identify as women who were born with ovaries. And I say that because we have absolutely no idea what the menopausal experience is for those who don't identify as women, for those who are using other hormones as a way to live their lives and what those impacts are having as they age. And that's also an area that needs some study. So I'm going to stop and say thank you for your attention and commitment to this topic.
Great. Thank you so much. That was fantastic. And I learned something new every time I hear about this topic. I'd like to introduce our next panelist, Karen Giblin. And Karen is she's the founder for Red Hot Mamas. In 1991, she served her third term as selectman in the town of Ridgefield, Connecticut, when she needed a hysterectomy with oophorectomy, and experienced, I knew I'd get that one, I'd stumble on that, and experienced surgical menopause. Following that experience, she founded Red Hot Mamas in North America and is a leading provider of menopause education and support in the US. Karen was a member of the Menopause Workplace Education Group within the Society for Women's Health Research, which recently conducted the employee perspectives and challenges concerning the transition of menopause that impact menopause study to improve the workplace experiences of individuals who have entered or completed the menopause transition. So Karen, I'd like to welcome you up to share some perspective. Thank you.
I'm delighted to be here today, and you might see a hot flash coming from this thing, but let's hope that the fire alarm doesn't go off. So every woman, if she lives long enough, will go through menopause at some point in her life. It's our trademark for being a woman. There has been a culture of silence about this phase of life, sometimes even secrecy, which leaves women uninformed, and they have no idea what to expect when menopause arrives, nor how to manage its course. So if you're a woman in this audience, and there are many, okay, and for your own well-being and that of your loved ones, I hope that after our 3 presentations, you'll be more aware of women's menopausal health. Today, I'm speaking as a person of wisdom about menopause in the workplace. Dealing with menopausal symptoms at work had a major impact on me. I was 40 years old when I had surgical menopause, which involved a hysterectomy with the removal of my ovaries. It caused me to enter menopause abruptly, plunged me headlong into an array of symptoms that were disruptive, intense, and much more severe than those associated with natural menopause. Hot flashes, night sweats, heart palpitations, fatigue, mood changes, forgetfulness were just a few that suddenly plagued me while I was a policy-making official serving my 6th year as selectman for the town of Ridgefield, Connecticut. During our town meetings, I instinctively tried to disguise my symptoms, even while I felt ravaged by the molten attacks of the dreaded hot flashes and annoying, sticky, drenching sweat. It was frightening for me when I experienced changes in my memory and concentration when reviewing and voting on my local town's ordinances. I felt embarrassed to discuss my struggles with menopause with those who worked with me. It became challenging for me to continue pretending that nothing was amiss. Finally, women in my constituency began calling me. I felt relieved when they began sharing their encounters with menopause. Seeing that menopause could be difficult and confusing time for women, I decided to develop Red Hot Mama's menopause education program. But even today, it still intrigues me why I concealed my menopause and how I dealt with it at work. Dr. Neil Perry just explained to us information about natural menopause, but I'd like to address surgical menopause. And hysterectomy refers to the surgical removal of the uterus, and approximately 600,000 hysterectomies are performed annually in the United States. If a woman has a hysterectomy and her ovaries are left intact, it will not put her into menopause. However, 55% of women having hysterectomies also have their ovaries removed, and this is called an oophorectomy. If you're premenopausal, when you have this surgical procedure, you'll go through menopause immediately. You'll suffer more severe symptoms than individuals who enter menopause naturally. And as I mentioned to you, I was fast forwarded into menopause this way. Well, each day in the United States, as Dr. Neil Perry said, 6,000 women enter menopause each day in the United States. A significant portion of those women, over 57% of these women, are in the workforce. And more than 80% of them will have challenging symptoms that they're coping with while at work, which typically can last anywhere from 4 to 8 years, but sometimes even longer. Some of these symptoms include debilitating hot flashes, difficulty sleeping, extreme fatigue, poor concentration, memory lapses, mood changes, inability to deal with stress, anxiety, joint pain, and a host of others. These symptoms should not be taken lightly because they can be uncomfortable and unbearable and adversely impacting women's lives, as well as their work performance, their career decisions, and some women even consider quitting their jobs due to these menopausal symptoms. Well, the consequences of this for employers are decreased productivity, absenteeism, retention problems, and increased healthcare costs. Many women never mention menopause while at work, even if they're having these embarrassing and significant symptoms. They don't reveal these symptoms because they don't want to be viewed as less competent, and discussing menopause may even threaten their job security. Well, greater efforts need to be made to raise awareness about menopause and to provide education, support, and protection to women who are navigating menopause at work. Building on the success of the Pregnant Workers Fairness Act, PWFA, it's a natural progression to introduce a Menopause Workplace Fairness Act. Just as the PWFA ensures reasonable accommodations for pregnant workers experience the natural limitations of pregnancy, a Menopause Workplace Fairness Act would extend similar protections to women experiencing perimenopause and menopause. And it's important to note that neither pregnancy nor menopause need to be defined as disabilities. Rather, these are natural reproductive related conditions whose symptoms warrant workplace protection and accommodations. So as an advocate for women all over the United States, I urge members of Congress to consider enacting a Menopause Workplace Fairness Act. Besides this legislative initiative, both public and private employers need to address menopause at work. I'm suggesting the creation of a Menopause at Work health awareness campaign, educating managers and staff about menopause, raising awareness about its symptoms, and increasing the availability of resources to help women. Several resources are currently available from the Society of Women's Health Research, which include the Menopause Workplace Resource Guide for Women and a guide for managers. And both of these great resources can be accessed online. Employers must also examine their work policies, invest in workplace training to educate their managers and staff about menopause, and make menopause-related accommodations for menopausal women to include temperature-controlled rooms, increased access to water and restroom facilities, cooling fans if necessary, easing dress codes or uniform requirements, allowing for more flexible work hours and intermittent leave of work if a woman is experiencing severe menopausal symptoms, and more telework options for women. It's important that employers make it known that they are willing to help menopausal women. Women need to know their employer has their back. September is Menopause Awareness Month, and October 18th is World Menopause Day. So let's use these months to step up and offer the necessary resources and support to women. So in my final thoughts, I hope you recognize that there is a clear need to take menopause at work seriously. Together, we need to help women overcome the barriers attached to being menopausal at work. So let's not take a nap. It's the right time and the right move to do this, because women shouldn't have to accept less than the best while experiencing menopause at work. Thank you kindly for having me speak today.
Thank you so much. I really appreciated your remarks. It's now my pleasure to welcome our final panelist, Dr. Janine Austin Clayton, Associate Director for Research on Women's Health and Director of the Office of Research on Women's Health at the National Institutes of Health. She is the architect of the NIH policy requiring scientists to consider sex as a biological variable across the research spectrum. As co-chair of the NIH Working Group on Women in Biomedical Careers with the NIH director, she also leads NIH's efforts to advance women in science careers. Most recently, Dr. Clayton has been instrumental in leading NIH efforts for the White House Women's Health Research Initiative and serves as a co-chair for data standards and research methods. Prior to joining the ORWH, she was the Deputy Clinical Director of the National Eye Institute for 7 years. Welcome. Thank you.
Good afternoon, everyone, and thank you for including me. Thank you, Cindy Hall and WCPI, for hosting this important event on a critical women's health issue. You can see from my slide here that the National Institutes of Health has funded research on menopause for over 30 years. ORWH was founded in 1990, so not too much longer than we've been founded, starting with the landmark Women's Health Initiative, one of the largest women's health studies ever supported. It was then Dr. Bernadine Healy, the first woman director of NIH, who started that study. The study of women's health across the nation, our SWAN study, looked at various diverse populations of women, Black, Japanese, Chinese, white, and Hispanic. And you heard from Dr. Neil Perry that we have now know because of research, women experience menopause differently. In addition, Ms. Flash was studied, which was a set of clinical trials that looked at various treatments and tested them to see if they work to relieve menopause symptoms. Ms. Flash stands for Menopause Strategies Finding Lasting Answers for Symptoms and Health Trials. And then just last year, our own annual Vivian Pinn Symposium, named for the first full-time director of ORWH, focused on midlife health of women, including menopause. And so when you look at who's funding this research, NIH has 27 institutes and centers, and you're not surprised to see that over half of the funding comes from the National Institute on Aging. But you might not be aware that other institutes also support menopause research. The Heart, Lung, and Blood Institute, the National Institute on Mental Health, the National Institute of Diabetes, Digestive, and Kidney Diseases, to name a few. And then the smallest piece of that pie chart represents other institutes that fund less than 1%. But it is the National Institute on Aging that funds most of this research. Next slide. And in terms of what are some of the kinds of studies that we're supporting, I promise you I won't tell you all of the $56 million, 127 projects that were funded in FY23, but I'm thrilled to be able to tell you that number because we now track that information through a system called RCDC. But I will tell you about a few. One is looking at a compound called phytocerm that promotes estrogen activity in the brain without affecting the reproductive tissues and organs, and such as the breast and the uterus. And so here they're examining whether this compound has the capacity to decrease menopause symptoms, and they're looking at whether it can reduce the risk of Alzheimer's disease development. Another is looking at the fact that when estrogen levels go down, as you heard from Dr. Neil Perry, there are consequences on multiple organs in the body, including the gut, the GI tract. There's increased permeability or leakage in the gut when estrogen goes down, and this can affect absorption of compounds and vitamins and minerals like calcium, which can affect your bones. So this is not just a one organ issue. This is a multi-organ issue. Another study is looking at the heart because the heart becomes more stiff, parts of the heart, the left ventricle. And so we're being able to explore ways to measure that over time. Another's looking at Alzheimer's development, estrogen receptor programming, and then neurovascular physiology of women. You heard about what's happening in the brain with these candy neurons. We need to understand what are the vascular blood vessel complications of those changes. And so as we look at midlife health of women in the center there, We think that a systems biology approach where you integrate all these different perspectives and consider how they are interrelated is a strategy that we could employ to better understand and better intervene to maintain high quality of life through midlife. So at the bottom of the slide, you see a life course perspective. You heard from Dr. Neil Perry as well about perimenopause, the transition, and then postmenopause, and that we spend about a third of our lives in this menopause period. So we need to address this from a life course perspective. So that study I mentioned called SWAN, they started by looking at people before they entered menopause. And you heard also from Dr. Neil Perry, this is a retrospective diagnosis. You don't really know if that period is going to be your last period. There's no way to know. And so you're looking, you're checking, and you don't know. There's no diagnostic test to tell us. But we need to look across that entire transition period to be able to understand what differences exist. And so we need to enroll women who may be 50 years old. Some may be menopausal and some may be not be menopausal yet. And so that helps us to understand the difference between reproductive aging, ovarian aging, and chronological aging. So it's not just about how old you are, it's also about the function of your organs. And did you know that your organs can literally age at a different rate than that number on your birthday cake? It's a different story. You can have a birthday cake for your ovaries too. So as we move on to the next, I'm going to highlight some of the gaps in menopause knowledge. There's a lot that we do know because of the investments that NIH has had in menopause research, but yet there's still a lot we don't know. We still don't understand how we can diagnose a menopausal symptom to distinguish it from actually this is part of a disease. You heard from Dr. Neil Perry. If you come in with a sleep disturbance, is it sleep apnea or is this sleep disturbance related to menopause? That's important because they're treated differently, right? We know that obstructive sleep apnea, for example, we have treatments for that. That's not the same as you would address it. So if you're not being able to say, I'm not sleeping well and I know why, and now I can do something about it, you're just experiencing the consequences of that. So we need better diagnostics. We need to understand about timing. You heard about the age range. People go through menopause in their 30s, 40s, 50s. What do we know about what is the best way to intervene to treat bothersome symptoms like debilitating hot flashes if you're 40 versus if you're 50? How long do you keep that treatment up? How long is it safe to? How long is it effective to? What's the optimal time of starting menopausal hormone therapy if you choose to use that? And what about the best timing to prevent chronic disease? Next slide. So we have looked at a variety of factors and including whether your bone health is affected by the timing of your menopause, your cardiovascular health is affected by the timing of your menopause, because menopause is a health inflection point. At that point, your risk of chronic disease increases. It's a turning point and it's a reset, and it's an opportunity to recognize that, to prevent the development of chronic disease, to delay the development of chronic disease, or to ameliorate. If you are becoming hypertensive for the first time, we can treat you earlier. We can treat you more aggressively so that you don't experience the sequelae, the consequences of uncontrolled hypertension or undertreated hypertension. So it is not just about the menopause. It is about what happens to your risk for chronic disease, how this affects every organ in your body, what it means for you, so that we can titrate and individualize your treatment. So we understand for you, a person like you, a person of your age, based on evidence that we have gathered from research that included people like you, these are your treatment options, and we can do shared decision making. And so in terms of, next slide, what we're doing now, we have an NIH-wide menopause research website on the ORWH website, nih.gov/women. You can get to this. It highlights the amazing work being done by the NIH institutes and centers and points you to other resources. There's the My Menoplan page that is a National Institute on Aging investigator-supported page that shows you Research shows this therapy would work for this situation. You can put in various characteristics and it'll pop up the research for you. You can print it out and take it with you to your healthcare provider and talk about that. And then in addition, I'm so thrilled to share with you, as part of this, one of the steps that NIH announced in response to the presidential memo announcing the White House Initiative on Women's Health Research, NIH ARC, in a program led by the Office of Disease Prevention, announced that we are attacking menopause and the questions that remain through a Pathways to Prevention program, which is a rigorous evidence-based approach to drill down and answer questions so we can definitively understand how to move forward. So that P2P, or Pathways to Prevention program, is underway. We'll be working with our federal partners on that. And with that, I am thrilled to be here with you today and look forward to our Q&A session. Thank you so much.
Great. Well, thanks to everyone for learning more about this important topic. And we're going to open this up to Q&A. So if you have a question, please raise your hand. We have folks floating around who can help with identifying you. But as you're thinking of your questions, one that I thought we would start with for everyone, for all of our panelists: healthcare training, public education, research, and/or workforce protections are areas ripe for public policy action when it comes to menopause. Within these topics, what is a key gap that you think must be addressed? Dr. Neil Perry, maybe we start with you.
The area that needs to be addressed is really the education of our providers about the menopause. And one way that I think we could do that is certainly many residency programs are funded through the government, and having a requirement of some sort that there is education around menopause and the many phases of menopause. So that would be my response to that question.
Who wants to tackle it next on some of the important gaps?
Happy to go if you want. Well, again, I agree. Many clinicians are not trained. They're not being trained to deal with the menopausal woman. And there's time constraints that involve when clinicians can see patients, there's a lot of time constraints there. So it's not only it's a confusing time for women, but it must be also confusing for clinicians who are not trained to deal with the menopausal woman and don't have the knowledge to equip them with the right answers during their menopausal stage.
Keeping with the same theme, I think that being able to better understand the best ways to manage symptoms for each individual woman would equip clinicians with the tools that they need to be able to deliver the best care to individuals. So we need all of those pieces connected together.
And I'm a real firm believer of educating patients, because I think they can be their own best advocate. And I think having a robust inventory that's really centered on menopause for people who are interested in learning more, so that they can actually have those questions. Because part of the challenge is, one, not recognizing, two, how to verbalize what the experience is and how to address those concerns.
I think that's absolutely right. So not only making sure that providers are ready to have the conversations, but that women feel equipped to have that. And I know research has shown that sometimes it takes a woman raising issues about her menopausal symptoms more than once to a provider before they actually can have that conversation. So I think there is a bit of prep for women to feel comfortable talking about it, but also the confidence to keep raising the issues if they feel like they're not being adequately addressed. What other questions do we have? Yes, please.
Thank you for this event today, this discussion. My name is Kimberly Wilson, and I actually run a platform for women of color that centers on women of color and their needs as they go through menopause transition. One of the things, thank God for the SWAN study, but I really, because without it, I really don't know what data we would have around how women of color experience menopause transition respective to race, culture, ethnicity, psychosocial factors. How can we first of all, where can we show up in other forms of research, not just the SWAN study? Will some of those projects that you talked about intentionally include women of color? And then two, there's another issue of how do we encourage women of color to be part of clinical trials and studies, because there's so much skepticism and fear, I think, of the healthcare system and medical research story. Thank you.
Do you want to just bring the piece of it, the community trust?
So, I think you really touched on a very important topic, and that's community trust. And, one of the most important things that any investigator can do is to invest time in knowing that community. And in my experience is that there are sometimes people want to just go in and do the research, but they don't necessarily share what they've learned with the community, and that's a source of distrust, but also not taking the time to understand what the questions and concerns are of the community, so that there really is a give, right? So that people can understand what the benefit is. This is not going to happen overnight. It is going to take time because there's a reason for that mistrust, and it's a valid reason. And I think having those conversations, people like yourself, helping people understand why it's important to be engaged. But the other piece about this is oftentimes women of color are excluded because the criteria for inclusion in the studies are you have to have a BMI less than 30. And more than 50% of women of color have a BMI greater than 30. So there are things that are systemic that actually exclude women who even want to participate. And so what you said, being intentional, so having studies that are designed and really embedded in the community, I think is part of that process.
I'd like to address this because I believe education is key for women. Okay, and education will make them feel less threatened about the menopausal process. I have a large program over 10 years at one of the major hospitals in Baltimore, Good Samaritan Hospital, and it's mostly women of color that attend those education programs. And after they go to these programs, they share their experiences with one another. Clinicians come in and impart their information about all aspects of the menopause. They feel less threatened, and then they are willing to go back to their clinicians because they have a thorough knowledge of some of the symptoms associated, some of the health risk associated. So, and they have a better knowledge of some of the health choices. So education for all women, okay, including women of color, is extremely important. And then I think there would be more receptive to going into the clinical trials and that.
Yeah, absolutely. You asked about different areas beyond menopause, and ORWH is leading an effort called the Understudied, Underreported, and Underrepresented Populations of Women, or U3. And we address all health disparity populations, including underrepresented racial and ethnic groups, but also individuals who live in underserved or rural areas, because we know they have less access. And we also know that a constellation of identities, race, ethnicity, gender, rural location, whether your socioeconomic status, sexual gender minorities, all of those identities can also affect your ability to access care. And so our U3 program is available on our website, and we provide supplemental funding on a wide range of topics beyond menopause, anything that affects a woman from head to toe. An investigator who's funded by NIH can apply for additional funding to add this U3 perspective. And so that's one piece of it. The other thing, just to piggyback on what Dr. Neil Perry mentioned about community trust and the importance of answering questions that are important to women as they experience and voice them, the COMPASS program, which stands for Community Partnerships to Advance Science for Society. I'm thrilled to be one of the co-chairs of that program. It was designed as NIH's first ever program that provides funding directly to community organizations like yourself, where the questions are coming from the community and the community organization partners with a research organization, not the other way around. And then we provide a coordinating center that provides technical assistance to that community organization directly. So that's called Compass. And so those are some of the ways that we're addressing these issues from an NIH perspective.
Great.
Thank you so much. Thank you for today's presentation. So I'm Claire Gill with the National Menopause Foundation, and I'm really excited that we are seeing some momentum here in Congress with several types of legislation being put forward. We have the WARM Act, which is being presented by Representative Blunt Rochester and Representative Harshberger. As one example, we have HR 8223, also by Representative Blunt Rochester and Yvette Clark. And there's also obviously legislation in the Senate as well that has been introduced. And I'm wondering, now that we have a panel here sort of representing academia and patient advocacy, and then the research elements within the federal government, how can we engage across those areas better to help bring about fruition of some of this legislation that's already been introduced? How, what's the next step of making sure all of us are acting on some of these opportunities that have been introduced?
Great. Who would like to take a go at that one?
I'll start, but my colleagues are going to chime in here. Events just like this are so important, and WCPI deserves all the kudos and shout outs today for bringing us together and sharing this information with each other and with you. Organizations like the one that you lead can help us get the word out because we want to do this in a coordinated, integrated, efficient, effective manner. So sharing that information and understanding what that menopause research agenda from our perspective, we want to see where are the questions that are most compelling. So I want to hear from clinicians like Dr. Neil Perry and researchers. I want to hear from individuals who are experiencing what is most important to them. So I just think that there's really no substitute for sharing the information. What do you think, Karen?
I agree. As I'm sitting here, I Red Hot Mamas was, I created that name, but I would think that a task force, menopause, okay, a task force, and brings about our components with patient advocacy, clinicians, and research together, okay, to work together to look at all, compile everything and make it known to the public. And more, again, advocacy for openness like we have today about menopause awareness, a menopause awareness health campaign.
I think they've said it all. I just dropped the mic.
And I think there's something to be said. Timing is everything. And so it does feel like this has been a great moment because of a lot of different factors elevating, the menopause conversation. And so what a lost opportunity if we don't really push forward. There's legislation that's pending. The White House has been engaged. So how do you turn kind of the moment into action? And I think that takes a multi-stakeholder approach. So thank you for the question, and Claire, for all of your efforts on behalf of women.
Hi, my name is Shelley Himes. I dressed for the occasion. I have a PR background, but a bestie and I started a company during COVID called Hot You're Not. So if you can see it says, I'm Hot You're Not Menopause. And the reason why I'm wearing this t-shirt and standing up is because we thought, and I think it's not spoken about often enough, but I think there has to be a better PR campaign around menopause. I think it has to be destigmatized. And look, I mean, I have night flashes, anxiety, mood swings, all that stuff, but I mean, it's kind of funny. Like pregnancy brain is funny, or it should be funny, or it should be cooler. We're not wearing mom jeans anymore, I mean, women who have menopause look fantastic in their 40s, 50s, 60s. So rather than go on, my question is whether you guys have thought about sort of a cooler PR campaign around menopause, and if not, I'd love to be a part of it. Or I'm suggesting that that should be considered as part of the whole program. And Red Hot Mamas is a good example.
Yes, and I can tell you how Red Hot Mamas came about. Okay. My young daughter, when I was experiencing hot flashes at age 40, okay, used to say, Mom, you're red hot. You're a red hot mama. So I said that was very apropos. And that's how Red Hot Mamas came about. But I agree with you. I think if you have a PR campaign, okay, to destigmatize menopause, it should be non-threatening. It should provide the facts about what to expect when menopause arrives and how to manage its course. And it also should have a little bit of fun around it too, because it's not all bleak. Okay, there's no more tampons. You don't need that. I hated that string anyway, to tell you the truth. Okay, and all the things that are underneath your cabinets. Okay, no more sanitary things under those cabinets. And so there is some benefit, okay? And yes, and some women say that they feel freer, okay, after the last period. So menopause is not all that bleak when it's finally over with. And there's a lot of life in us during the menopausal years too. So we have to have fun with it as well.
It's the best excuse. It's like, pregnancy brain. I lost my keys, menopause. I was mean to someone, menopause. I forgot to call you back, menopause. There are a lot of uses.
Yes.
I just have issue with mom jeans. I still wear them. No, I agree with you because there are definitely funny moments and you have to be able to laugh at yourself. But part of being able to laugh at yourself is recognizing that it is not a bad thing, right? There should be no stigma, right? Actually, when I talk to patients about it, I do add a little humor. It's like, well, you're going into menopause. It means you're getting, older, but what's the alternative to getting older, right? So this is actually a good thing. It means that you have lived a good life, right? When you think about, 100 years ago, women often did not live into their 80s. So it speaks a lot about transition. There comes that freedom, freedom of the pad and the tampon as expressed. But it's an opportunity. And that's how it should be perceived. And again, many of the symptoms that are that may be considered most disabling are not long lasting, right? It is finite. And I think that's really the message, that it's the symptoms that are debilitating are finite, and that, there's a phoenix, right? You rise out of the ashes and you're brighter than ever. And I think that's the message. So I agree with you.
One thing I want to bring up though, that not women, a lot of women blame everything on menopause. There could be a lot more going on with their health concern, and they need to have regular visits with their clinicians because they can't blame everything on menopause. Do you want to address that? Yeah.
Absolutely.
Okay.
What I will say is that the symptoms of menopause can be so vague, and it can be very difficult to really recognize what they are. And even as a reproductive endocrinologist who studies the menopause, when it happened to me, I was a little bit oblivious, right? And it was like all of a sudden it was this light bulb. Oh, this is what's going on. And, it's so important to have these conversations. I encourage patients to have conversations well before they're menopausal, well before they're perimenopausal, so you can have some idea of what to expect, right? What not to expect. And to really have that open dialogue with your provider, and as was mentioned about shared decision making, right? Knowledge is power. And with that knowledge, we can make decisions together that are best for you.
And also, menopause just does not affect the woman. It affects those around the woman. So their family members, their loved ones should all be educated about the menopausal woman. That's very important.
Great. Go ahead.
Hello, thank you for this panel. It's been amazing.
My question is sort of reflecting on some of the things, the barriers of treatment that Dr. Neil Perry mentioned. I'm wondering, where do we begin or how do we start in redressing this cultural idea that a woman's worth is so heavily tied to the cultural currency of her youth? And by that same vein, how do we encourage the women in our lives that are going through menopause that they deserve to advocate for themselves, regardless of the fact that it's been so heavily primed for them that their right to advocate is contingent upon beauty and vitality?
I can take that question, and I think it's important. Events like this, that is what this is about. People like you can make a difference, right? It's about normalizing. This is a normal part of life, right? Just like puberty, right? We don't disown people because they're going through puberty, although we may want to. But it's a part of life. It's a transition. It's a natural process. And just having that conversation and asking questions like, Mom, what was your experience? Nana, Grandma, what was your experience? And, I need to know so I can understand what to experience, right? And just really encouraging that discussion and having, TikTok. I'm not, I just barely know what TikTok is, but, talking about it in places where there's wide, view so that people know this is something that we should be talking about. So I think it starts with you.
Great, thanks. Yeah, go ahead.
So I'm curious if any research is being done kind of longitudinally on whether women take birth control for how many 5, 10, whatever, if that will impact the age at which they cause.
There's not a significant impact. I know there are people who think that actually if you use birth control pills, you'll have an earlier menopause. Urban legend, absolutely untrue. There's not a significant impact. The reason that you see both estrogen and progesterone is because if you have a uterus, you must have progesterone as part of your treatment to prevent cancer of the uterus. And that's why you see both estrogen and progesterone. And keep in mind, why birth control pills have estrogen and progesterone, if you have a menstrual cycle with ovulation, you make that every month. And the levels that you create are a lot higher than those that are in a birth control pill.
But in the perimenopausal woman, it could be of great benefit to some of the symptomatology that's associated with menopause. Can you explain that?
Absolutely. So, can you hear me?
No. Your thumb is on the.
Oh, okay. There we go. So there are two groups that often have unexpected pregnancies. Teenagers and perimenopausal women. Because they think I am perimenopausal and I can no longer get pregnant. And literally will be like, how did that happen? It's like, do I really have to tell you? So my point being is that in perimenopause, it's helpful, birth control pills for the symptoms, but also if you're not wanting to have another child, that, it's also helpful for contraception. So I'm going to put that little plug in because people think if I'm perimenopausal, I can't get pregnant. And I'm here to tell you that is another myth, that it does happen.
Great, yes.
Hi, my question is, I heard some discussion about the need to have employers more supportive of women experiencing this. Is there research available to help make the business case for these proposed policy changes?
So I am aware of some research that does make the business case in the UK, looking at cost of absenteeism or presenteeism related to menopausal symptoms. And there is data from the US too about if you have people at the prime of their productivity, not in the workforce or partially in the workforce, and maybe Karen can pick up here, it makes sense that you're going to lose productivity. and none of us want to like onboard new staff. So I think we have enough data to show that we affecting women in the workplace of all ages, whether it's related to pregnancy symptoms and limitations that might exist that are not disabilities, or menopause symptoms that may affect an individual's workplace presence. We have the evidence to show that there's an economic impact. What do you think, Karen?
Well, we have in our audience someone that could probably speak to that, and that's Irene from the Society of Women's Health Research, who has done a lot of research in this
Dr.
area.
Renier.
Thank you. My name is Erin Meany. I'm the Chief Science Officer of the Society for Women's Health Research. And we did, Karen mentioned a study that we did, the Impact Menopause study, looking at the impact of menopause in the workplace, not just for perimenopausal and postmenopausal women, but also for their employers and their coworkers. And so I think putting that together with some of the economic data and some of the other studies as well can make that case from a more complete perspective. So while we understand that there's the lived experiences, also looking at what the economic and social impacts are.
Great. Other perspectives on impact of menopause on employers? I know, Claire, you also may have some perspective. You're good. Yeah. Lots of, yeah, absolutely. Other questions? Yeah, in the back.
Oh yeah, I guess this kind of goes along with the idea of employers, but what are we doing or could we be doing to include men in this conversation? Because the reality is, employers work with men, like making sure that they're informed that while this issue impacts women, it also by increasing their knowledge, like they're aware of it.
That's a great question in terms of how do we include men in this conversation. And there is an active effort to do that because, again, it's been said once, it's been said twice, and I'm going to say it again, is that symptoms of menopause and the way that they may disrupt the individual with menopause's life, it also impacts the lives of those around them. And oftentimes there are men that are involved. I have done events and educational activities around menopause. And I can tell you that it is not all women who are present. And so there is active engagement and interest in learning about how can I support my partner, my family member through this process. And I think, again, it's about, education. In some ways, maybe a public statement like don't smoke, that we have some statements around, what menopause is like and how it impacts those around us.
Red Hot Mamas has been offered in a lot of different hospital settings all over the country. And typically when we host a Red Hot Mamas program at a hospital, there's like could be 200 women and men in the audience. Okay. So they do come to menopause programs to find out about their loved ones. But I have to share a story with you. This is a funny story, and this is a true story. I was doing a talk, at Vassar Hospital, and there was a couple men in the audience, and there were full packed house, 250 people there. And I went up to one man after the menopause program. I said, how nice of it of you to learn about menopause about that's affecting your significant other or your wife. And he looked me in the eye. He came to this menopause program. He said, I came to meet women. Oh my God. That is a true story. That is a true story. But it's important that menopause does, as I mentioned to you before, it just does not affect just the woman. It really affects anyone who is their friends, their loved ones, and the whole picture. And it's not unusual that education programs that I've had women bring in their children as well, to learn about what's going on because that they are affected as well. So education is key for everyone, okay, to learn what to expect when menopause arrives and how to manage its course. So
well, and if I can offer my perspective, I think part of this is just making it part of the conversation. And we talk about menopause around the family dinner table. I have 3 daughters, but my husband gets to benefit from that conversation as well. So hopefully, when he's in a situation, he feels less uncomfortable. I don't know that he'll feel completely comfortable, but part around removing stigma applies to men as well and allowing them to engage in the conversation. And I will say, in some of the policy conversations we've had from a Hill perspective, there are lots of male and female staffers who are and members of Congress who are interested to engage, want to know more. And it's such a great issue because it affects all women. It's something we're universally going through. So what a great way to support women on their journey. So I think also helping men see that perspective just elevates the conversation, but a really important issue and perspective. So thanks for bringing that today.
it's our trademark for being a woman.
Other questions? Yeah.
Sorry, I don't intend to dominate. Because we're having a policy conversation, I do think one of the things that we don't talk enough about is also accessibility and affordability. It's a pocketbook issue, right? An old data point, but women spend up to $2,000 a year on treatment options, trying to find a treatment solution to their symptoms. If you're in menopause for up to 10 years or perimenopause, like myself, that could be upwards of $20,000, right? So I think we also have to talk about accessibility and affordability, and with menopause telehealth clinics popping up, is that an option? But it's also, I think, becomes more of a burden, an onus of the employer to offer solutions, right, to their workforce. That includes shift workers, line workers, and hourly workers, right? We have to make sure that that's included in the part of this conversation.
I appreciate that comment about access. When oftentimes when I am managing a patient with menopausal symptoms, they come back and tell me, I cannot afford this medication because my insurance won't cover it. And that is that's a hard conversation when you know that this will benefit, and it did benefit the patient, but they can't afford it. And so I think around policy, that's a really important point, that women have access to not just one treatment, but multiple, known effective treatments to ensure that they find the best treatment for themselves, because that is definitely a real issue for patients who are seeking care and management of their symptoms.
We have time for one final question, and then we'll go to the lightning round at the end.
Barbara Hannah, I'm a OBGYN and a Menopause Society certified practitioner and founder of a telehealth menopause company that accepts health insurance. Policy regarding telemedicine is prohibitive to scale companies easily to improve access to care. Our current policies lag what's really happening in the real world. And in addition to that, co-pays and out-of-pocket expense, when you look at the amount of women or individuals who have high deductible plans, when they have a menopause care visit, that's goes towards deductible. And so then you factor in the cost of medications, and it really becomes very unaffordable for patients to access care or continue care. And so I think as we talk about fantastic research opportunities and we talk about education, we also need to really drill down, how do we improve access to care and make care cost effective so that women can get treatments when they opt to do therapeutic treatments, or even opt to just have a conversation with a menopause trained doctor.
I think we're about at time. Did you have a final point?
Yes, sort of. So at the very beginning, people were talking about how important
educating our healthcare providers are. And I'm a trained internist, sort of, I'm an epidemiologist, that sort of thing. But my thought, my belief is that most of the time when a physician or a nurse practitioner or a PA who isn't taking care of gynecologic problems has a woman come in and complain about this, she sends that woman to the OBGYN or the nurse midwife. Am I correct? Are there data that talk about how often the non-reproductive health professionals are seeing people, women with menopausal symptoms, and not sort of thinking about it? Because that's another thing that affects access, affects affordability, because now I got to go to another doctor, right? And also, back to Janine's point, which I thought was really important, is that a lot of menopausal symptoms are thought to be menopausal, but there's something else. And maybe that rheumatologist needs to be thinking about this. But if the rheumatologist, if the one says, I'm having menopausal symptoms, and she says, go to your OBGYN, who is not trained extensively in rheumatology. So I think we may need data about how practitioners, not just physicians, maybe we can leave pediatricians out, what do you think? but all other, I think we need to understand how those practice settings work.
Thanks. So in our final few minutes, just wanted to wrap up by asking each of our panelists, what are one or two primary takeaways you hope that the audience or policymakers attending will consider in their work? So a little bit of a call to action, or what are the things you want as the takeaways? Do you want to start, Dr. Clayton?
Actually, picking up on what Dr. Elise said, I think that the role of primary care in the care of women is underestimated and untapped potential. We know that, for example, contraception, gynecologic care, pregnancy care happens in primary care. Why not menopause care? So that's an opportunity. But I also want to pick up on a point I made earlier and make sure that everyone leaving here understands that in addition to the symptoms of menopause is this health inflection point where chronic disease risk can increase, but you can do something about it. And that's a real opportunity for prevention, for amelioration, for early diagnosis, and a known time that we can intervene. We don't have a lot of situations like that. We have that with pregnancy. Something new is happening, we can intervene. And so we don't also know, if we know that there's an increased risk for chronic disease progression, what is the effect of menopausal hormone therapy on that chronic disease development and eventual outcomes? That's one of the questions that is on my mind. What about you, Karen?
Well, since I was here to address menopause in the workplace, I think that menopause should be a top priority within our society and within the United States government. And as we learned today, menopause can have a significant impact on women who work. And as I mentioned to you before, a significant portion of us, are in the perimenopause and menopause and are in the workforce. So therefore, I would urge Congress to consider in introducing a Menopause Workplace and Fairness Act to extend protection to women who are experiencing perimenopause and menopause while working, and to provide reasonable workplace accommodations for these women. Public and private employers should implement some of the recommendations that I detailed in my brief talk this morning. And I think that more awareness should be created to menopause to improve all workplace accommodations for menopausal women.
Yeah, great. I think one of the things that I highlighted that I know that many people don't know is about the differences in the menopause experience across race and ethnicity. And as was previously mentioned, one of the reasons we know that is really because of one one longitudinal study of women across the nation. Without that, we wouldn't know. So I want to encourage policymakers to invest more in research that's focused on understanding the cultural impact as well as racial and ethnic differences. I really appreciate the idea and the concept of having centers of excellence, but I think we need to be intentional, and some of those need to be embedded in those communities that have reduced access, such as our rural communities, such as our communities of color, where we know the symptoms and the consequences are graver. And so that is one issue I think we need to address. And the other issue is around education. And that is on both ends of the spectrum, both for the patient as well as those who are providing care. And there are studies that have looked at primary care providers and their referrals or not referring patients with menopausal symptoms and not necessarily recognizing those symptoms. And we need to understand that more and use that as a vehicle to educate and to empower the provider, because part of that concern is concern about the Women's Health Initiative study, an important study that really told us about we're using hormonal therapy in a very indiscriminate way and that it's not appropriate for everyone. But it was the impact of the study was well beyond the study population. And we're still seeing our providers terrified that they're going to be the cause for a cancer or a stroke in a 40-year-old who needs hormonal therapy. And that's kind of part of that process. So educating both the patients, because patients also have the same concerns, as well as the providers, I think is very important.
Great, thank you. And I'll just add, menopause is a bipartisan issue, and it's something that is ready for continued action from a policy perspective. There's so many different areas, and I really am pleased that we're able to touch on so many in our conversation, whether it's biological impacts, research, employee impacts. And so really a call to action to all of you is to keep the conversation going. And thank you for your time today and the active engagement. What a great session, and a huge thank you to our panelists as well. So with that, Cindy, any final remarks?
Yeah, we really could end right there, Christy. You're right. I have to say too, thank you to our panel and to Christy and to all of you. I mean, great questions. I thought this discussion was really more than I expected, and I expected a lot. So thank you so much for your inspiring presentation, so informative. Everyone was brief at the beginning so we could have such a long question and answer period. And Christy, you did a great job of moderating. So thank you so much to all of you. It's very clear there's significant interest. I was also struck by the different ages asking questions, which was wonderful to see. We don't always see that with some of the topics we cover. So this is definitely, as Christy mentioned, this is sort of the time. You can always tell the Hill is very, you better do it when you have your moment. It feels like this is the moment. And also just a note, this conversation was recorded. It should be available by next week. We need to always do some editing, so it takes a little longer than we'd like, but that should be widely shared. We hope all of you will do that. We certainly will be doing our best to do that. I would be remiss if I don't mention the short survey. There are QR codes taped to most of the chairs. So we hope you'll take the opportunity to respond. Also, anyone attending remotely, you will receive the survey shortly after this event ends. So we really hope you'll fill it out. I want to thank again the Bipartisan Women's Caucus leadership. Unfortunately, thanks to the way the votes have been happening today, we did not have them represented, but their staff were here, and we know that they'll get a lot of this information later. Thanks, of course, to Estellas for your incredible support of this event and this issue. And then last but not least, my thanks to the WCPI team, Alyssa Innes, Policy Director back there, Afnan Adam, Krista Camarda, Annabelle Green, Kendall Tyakaran, Beatrix Sherry, and Tatum Tatch for their work to make this event a success. Thank you so much.